Hello my friends, welcome back to Cardiac Academy. In the last video, we finished up all of the supraventricular arrhythmias. So in this video, we're gonna finish up with the ventricular arrhythmias. So without further delay, let's get into it. Okay my friends, let's talk about ventricular arrhythmias. So ventricular arrhythmias. So ventricular arrhythmias are any rhythm that develops below the AV node. So in the previous lectures, everything was supraventricular above the AV node, with the exception of the junctional rhythms, which came at the level of the AV node. In this lecture, everything is below the AV node, okay? So it's ventricular. So, like we said, arises below the AV node, and the most common arrhythmia that you're gonna encounter are the PVCs, or the premature ventricular contractions, okay? So PVCs are usually caused by irritation of the ventricle for whatever reason, but it can also be seen on healthy hearts. So the PVCs, you're gonna be able to identify it because it's gonna be a wide QRS, very different, very bizarre, and you're gonna also see a secondary repolarization abnormality, just like we see in this image. So here you can see like a normal depolarization. You see a P wave, narrow QRS, and all of a sudden you see this wide QRS without any P waves. This over here is not a P wave, this is a T wave, okay? So you see wide QRS and a secondary repolarization abnormality right here. You can see this, this wave which comes right after the PVC. Almost looks like a T wave inversion, but this is all because of the abnormal depolarization. Remember, an abnormal depolarization will cause an abnormal repolarization, okay? So usually when you see a PVC, you're also gonna see a compensatory pause before everything restarts again. You can see in the next QRS, or the next depolarization, is a normal sinus rhythm depolarization. You see a P wave and a narrow QRS, okay? So isolated PVCs, like we said, can be found in normal healthy hearts, but if you see a PVC in the setting of an MI, that's different. Those are more malignant and more dangerous, okay? So you can also classify PVCs in how often they appear. So you can see a normal QRS and then followed by a PVC, and then back to a normal QRS and then a PVC. That is called the Gemini, okay? And you can see an example right here. So here, the first depolarization, you can see it's a normal depolarization, and all of a sudden we have a PVC, okay? And you can see how this T wave that is following the PVC looks different from the previous one, and so does the QRS. So that let us know it's a PVC. Then we're back to normal, and then back to another PVC, and so on. So this is called the Gemini, okay? But we can also find different types of PVCs to QRS ratios, okay? So let's try to guess the name of these ones, okay? So here, let's try to guess the name. So we have normal, normal, and then one PVC, then normal, normal, and then one PVC. How is this called? What do you think? So in this case, it's called trigeminy, okay? Very good. Let's see the next example. So in this case, we see normal, PVC, normal, PVC. So how is this called? That's right, the Gemini, okay? Now the last example, we see that we have a normal, 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 and then a PVC. So 3 consecutive normal depolarizations and then one PVC. How is this called? That's right, quadrigeminy, okay? Quadrigeminy. Okay, quadrigeminy, okay? So bigeminy, normal, PVC, normal, PVC. Trigeminy, normal, normal, PVC. And then quadrigeminy, we have normal, 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 and PVC, okay? Now here we have a bonus. So what are we seeing here? We see 2 consecutive PVCs. How is that called? That is called a couplet, okay? 2 consecutive PVCs is called a couplet, okay? Very good. Okay guys, let's do a clinical case together, okay? So a 33-year-old female student who complained of an irregular heartbeat had an EKG done by his PCP at clinic. The PCP knows that you are subscribed to the Cardiac Academy YouTube channel and asks you to please interpret the EKG for him. Apart from an irregular pulse, her heart was clinically normal. So what did the EKG show? All right. Okay, so again, like always, let's use our mnemonic, erratic, okay? So let's start by writing our mnemonic on the corner. All right, so first R is for rate, okay? So here we don't have a rhythm strip, so we're kind of forced to use only the first method, okay? But it seems pretty simple, so we see 300, 150, 100. So 100 beats per minute. Let's change color. 100 beats per minute. Then the second R is for rhythm, okay? And for rhythm, we have the 5 questions. Are there any P waves? And yes, we can see some P waves. It's easier to see them here in lead 1. So we have P waves. Is there a P wave for every QRS? And we can scan, we can see P waves also here in lead 2. We see them on AVL as well. So yeah, there's a P wave for every QRS. Is the QRS narrow or wide? And we see most of them are narrow, but we do see some wide QRS complexes, okay? Then is the rhythm regular or irregular? And for the most part, it seems to be regular. And finally, is the PR interval prolonged, more than 200 milliseconds? It's not, okay? All right, so we can say this is normal sinus rhythm. So normal sinus rhythm, but we are seeing some PVCs, right? So normal sinus rhythm with PVCs. A is for access. We look at lead 1 and we see that it's upright. And we look at AVF and it's also upright, so that's normal. So normal. Then we look at T is for T wave, but in reality what we mean is QTC, right? To make sure it's not prolonged QTC. And for that, we don't want the T wave to be more than 50% in between QRS and QRS. So let's look for a lead in which we can see them clearly. So here in AVF, we see here's a QRS, here's a QRS, and the T wave is right here. So it's not more than 50% in between them. So it's not prolonged, it's normal. Then I is for ischemic changes. We look for Q waves, ST depression, ST elevation, and T wave inversions. And we do that in following anatomical regions, okay? So lead 1, AVL, V.5, and V.6 for the left lateral leads. And we don't see any Q waves, we don't see ST segment elevations or depressions, and we don't see any T wave inversions either. Then we look at the inferior wall, looking at lead 2, 3, and AVF. And the same applies, there's nothing to suggest ischemic changes. Then we go to the septal leads, V1 and V2, and there's nothing there either. And finally, we go to the anterior leads, V3 and V4, okay? So let's talk a little bit about these PVCs that we're seeing here. So I'm gonna clean this a little bit so it's easier for us to see. And I'm gonna close up to the PVC. So PVC, we can see it's a very wide QRS. There is no P waves. We can see that here. And then we see a secondary repolarization abnormality. So this does not count as a T wave inversion because this is secondary to the PVC, okay? And as we said earlier, no P wave, okay? It's a PVC, it's a premature ventricular contraction. And on a young lady, like the one from this example, it's probably benign, nothing to worry about. There's only a few here and there, so nothing too worrisome. And just to be complete, let's do chambers, which is for left ventricular hypertrophy or right ventricular hypertrophy. So there's no right ventricular hypertrophy because there's no axis deviation. and it does not meet the Sokolow line criteria or the Cornell criteria in this particular EKG, okay? So in conclusion, we have normal sinus rhythm with occasional PVCs, okay? Very good. All right, so when are PVCs actually dangerous? So there are some rules that could suggest that PVCs are malignant, okay? So let's go over them. So 5 main rules. Are there any frequent PVCs? So the more frequent these are, the higher the likelihood for these to cause issues down the road. Are there continuous, especially 3 in a row? 3 in a row actually defines V.Tach, ventricular tachycardia. So let's write that. So more than 3 equals V.Tach. Then does the PVCs have different morphologies? So why different morphologies? Because if the morphology vary from one to another, it means that they have different localizations in the ventricle. So they're coming from different places, okay? Then a PVC falling on a T wave, that's super dangerous. It can actually cause the rhythm to convert to either V.Tach or V.Fib, okay? So PVC falling on T wave, very dangerous. That's one of the rules of malignancy. And finally, any PVC occurring after an MI is very dangerous, okay? Good. Okay, let's go over some examples. So first, we have here a normal depolarization, and then we see 2 PVCs with different morphologies, okay? And then we go back to normal, and again, we see another PVC. So in this case, we're meeting 2 of the rules of malignancy. 1, frequent PVCs. And then the second one, we have PVCs with different morphologies, meaning they're originating from different places in the ventricles, okay? So that makes them more dangerous. Next example. All right, here, let's go over them. We have normal sinus rhythm here and here. And then all of a sudden, we see a PVC, which guess what? It fell on an T wave, causing the rhythm to degenerate into V.Tach. You can see that here, how it changes its morphology. You can see how it fell here, and then all of a sudden, V.Tach, okay? Which is one of the most dangerous of the 5 rules of malignancy, okay? That's why it's so dangerous. It can cause very life-threatening arrhythmias. Now, even though PVCs can be dangerous in the setting of the 5 rules of malignancy, there is no proven benefit to treat them or prevent them with antiarrhythmics. In the case of someone who has a high PVC burden and they feel very symptomatic, you can try to start something for symptom relief, but it's not going to do anything for mortality, okay? All right, so let's talk about V.Tach, ventricular tachycardia. So the definition for V.Tach is actually 3 consecutive PVCs, okay? And V.Tach can actually be classified as monomorphic versus polymorphic. But before we go into that, let's think about how to diagnose sustained versus unsustained V.Tach. So sustained V.Tach is ventricular tachycardia that lasts for 30 seconds or more, and non-sustained is V.Tach more than 3 PVCs does not meet that criteria. So if you think about it, can you actually diagnose V.Tach on an EKG? Well, in reality, an EKG only records 10 seconds. So you could make the argument that you can't really diagnose V.Tach on an EKG. You will need like 3 EKGs. But what you actually need is telemetry, in which you can record more than 30 seconds. But let me tell you, someone with V.Tach of 10 seconds is going to be symptomatic. So you will know, okay? So here we have the examples. We have monomorphic tachycardia, V.Tach. So we can see how the shape does not vary much. That's why it's monomorphic. And compare that to the second example, polymorphic V.Tach, which is each wave looks very different from the previous one. So that's polymorphic V.Tach, okay? So monomorphic is mostly seen in scar tissue. Basically, old infarcts will cause monomorphic because now it's more difficult for that depolarization to flow. Now, polymorphic V.Tach is more dangerous, and often you will see it more on acute MIs, okay? Now, ventricular fibrillation, that's the most dangerous of all, and this needs emergent defibrillation. Otherwise, the patient will die. As you can see, and in this example, you can have coarse V.Tach, like in here, in which it's, coarser. It almost looks like V.Fib. It almost looks like V.Tach, but it's actually V.Fib because you can see how it later becomes more fine fibrillation waves here. So you can see that this is not V.Tach, it's actually V.Fib, which changed from a coarse V.Fib to a fine V.Fib, okay? And the last example of ventricular arrhythmia is torsades, okay? So torsades is very unique in the sense that you're gonna see how it almost has like a bow-shaped look. Torsades mean torsion. So torsades, torsion of the points. So that's why it kind of looks like a bow. It goes up and then goes down and then up again, like in this example. And it's usually seen with what I call the hypos, hypocalcemia, hypomagnesemia, and hypokalemia, okay? So try to remember it that way. The hypos will cause torsades, okay? So try to always replete your patient's electrolyte to avoid this kind of arrhythmias, all right? Very good. Okay, and then finally we have accelerated idioventricular rhythm. We kind of talked about this already in a previous video, but the point I want to make this time around is that after an acute MI, you could potentially see an accelerated idioventricular rhythm, but in this case, it's actually benign and usually transient. It doesn't mean that your patient is going to have a worse prognosis because they develop an idioventricular rhythm. It's just something that you may see, okay? All right, very good. So let's practice now. So what do you call this first example that we're seeing here? That's right, it's a PVC, okay? Next example, how is this called? We just talked about it. It's V.Tach. Next, V.Fib. And the last one, torsades. Very good. Now, what are the 5 rules of malignancy? Can you remember? Well, let's go over them. So the first, frequent PVCs, okay? The more the PVCs you have, the more dangerous. Then whether they're consecutive or more, or no, or not. So 3 consecutive PVCs define V.Tach, okay? Multiform PVCs, because that means that they're coming from different locations in the ventricles, are on T phenomenon. This could develop V.Tach and later further develop V.Fib, okay? Then any PVC occurring after an MI is also considered dangerous, okay? Excellent. All right, so just looking at this EKG, what do you think is going on here? It's a white complex QRS, same morphology, right? It doesn't vary, so this is monomorphic V.Tach. Is it sustained versus unsustained? Well, here we have 10 seconds, but my guess will be this is probably sustained. We just have only evidence for 10 seconds, okay? All right, let's do one final clinical case together, okay? So a 55-year-old man presents to the ED complaining of chest pain. While the nurse was recording the EKG for you to read, the patient collapsed while his EKG was still being recorded, okay? Kind of redundant, but let's go with it. All right, so it's late, my friends. So let's start with our mnemonic, okay? So erratic. Okay, so rate, we can see is pretty bradycardic. We can try to calculate here. It's probably going to be easier, although we have some PVCs, it might be slightly inaccurate, but we can say 300, 150, 100, 75, 65, 55, so in between 65 and 55 beats per minute. So let's call it 50. Then rhythm. Rhythm are the 5 questions. Are there any P waves? And we're looking here. Yeah, I can see a P wave up here. And there's a P wave here, here. So yeah, there are P waves. Is there a P wave for every QRS? Well, we can see them, but we also see other stuff going on. But I will say yes. Is the QRS narrow or wide? Is narrow for the most part, but then we do see some PVCs here. This is a PVC. This is a PVC. And here we see a lot of stuff going on. We're going into it in a minute. Is the rhythm regular or irregular? Well, it's irregular because of the appearance of these PVCs, but it's actually a regular rhythm when the SA node is the one driving the heart, okay? But yeah, I would say it's probably irregular due to these PVCs, okay? Not due to any AV node issues or SA node issues, okay? Then is the PR interval prolonged? No, it's not. It's normal. Okay, access. Here we only have lead 1. We don't have AVL, so we can't really assess the access in this case. So I'm just gonna say that we can't, and I'm gonna say normal sinus rhythm with PVCs that then develops into, we're gonna go over it. Okay, T waves. So let's look at one of these. This is a T wave here. So is it more than 50% between QRS and QRS? It's not, so it's normal. Then ischemic changes. And we're gonna try, we really can't do this in an anatomical region, but let's look at lead 1. In lead 1, we're actually seeing some ST depressions. You see here. Let me just clean this up so we can, well, they're right here. These are ST depressions. And if we look at lead 2 and 3, you saw these are actually ST segment elevations. So we're actually seeing STEMI here, okay? ST segment elevation, myocardial infarction, and we're also seeing some reciprocal changes in the lateral leads. We only have evidence of lead 1. And so let's say we have a STEMI here. And it's an inferior lead, so inferior MI. And then chambers, we can't really assess for the Lyon-Sokolow criteria or the Cornell criteria, or we don't know whether there's an axis deviation, even though it seems like there's not, but we can't really assess. So let's talk about this rhythm that we see here, okay? I'm gonna clean up a little bit. So clearly, we see here a normal P wave and a QRS and an ST segment depression, but we see that a PVC fell right here. So it fell on a T wave. And what did we say about PVC falling on a T wave? It can cause V.Tach, right? So it's one of the 5 rules of malignancy. And we can see V.Tach right here for the first few beats. But then it starts changing. And we can especially see that here, it turns into V.Fib, okay? And in the lead 3, we can even make the argument that it developed torsades. We can see here that switching of the points, right? So this is a very interesting EKG. So we have a PVC falling on T, causing V.Tach to develop, which later changes to V.Fib, and we could even make the argument that this patient is having torsades de pointe, okay? All right, interesting, very good. Okay, my friends, that's it. I really hope you liked this video. Please like, share, and subscribe, And as always, I'll see you at the Cardiac Academy.